Okay. So today, just in terms of our agenda, we'll talk a little bit about the background for the study and motivation, the study itself, and then have some time for a group discussion and interpretation of findings. But first, I just wanted to acknowledge some people who have contributed to this work. So I have a couple or a few co-investigators on the project. Aaron Gottlieb from University of Chicago, Nev Jones is here with us today, and Amy Watson, who's now at Wayne State. And also I had three really, really amazing student investigators. I won't even call them research assistants because they really are like their own investigators on this project. They were so engaged. That's Priya Gupta. She is here with us today, as well as Catherine Look, and both of them will be presenting a little bit. And then Tom Miller was another wonderful one of our bachelor students who assisted mostly with recruitment of participants. And then as part of this project, I also did some preliminary work speaking with experts, both on mobile crisis and clinical interventions in community mental health, as well as methods. And some of those folks are here today too. So thank you to them, especially Katie, Toya. I don't know if Travis is here, but Christina, I see you. Jack Rizal, the clinical director of Resolve Crisis Services here in Pittsburgh, and Tanya Slawinski. And then, of course, a thank you to all the participants and the Pitt School of Social Work, who funded this study through the Florence Steyer Research Development Award. I feel like we really made good use of this like tiny little award. I mean, it's not tiny, but it felt tiny compared to the funded proposal I saw, where basically people are doing this exact same study funded by NIJ for like $500,000. And so I feel like we were really resourceful with our $15,000 for this project. And then, as always, indebted to Mary Beth Rocktis for keeping us all together and keeping us stimulated in terms of research, and to Rise Mental Health. So as you may be aware, mobile crisis is a hot topic right now, as are all services on the crisis service continuum. And the reason for this, in part, is because of legislation that was passed in 2020, which created 988, the Suicide and Crisis Lifeline. So this 988 is supposed to be an alternative to calling 911. So part of the motivation is to help steer people who are experiencing mental health crises away from law enforcement responses towards more appropriate responses from the mental health system. And there's also a secondary goal of helping to, relatedly, helping to keep people with mental health problems outside of jails and prisons. 988 it has been implemented. It has been disparately funded, so not all states have any funding attached to 988, and so that has caused a lot of problems. But it has also really inspired a kind of like reinvigoration of our crisis service systems across the country. And so every Wednesday afternoon at noon, you can turn into the Crisis Jam and learn about various issues related to crisis intervention across the country. And they feature speakers, experts about everything from like peer involvement in crisis services to crisis services specifically for young people or people with intellectual disabilities. And then also, we have an increase in funding for research on this topic. So, for example, here's a NOC from an AMH on research opportunities in crisis response services. So a lot of interest in crisis intervention in general. And when we're referring to crisis intervention, we're really speaking about like the immediate response to some mental health emergency. And mobile crisis team members are really integral parts of any what would be called like a comprehensive crisis system. So mobile crisis teams are specially trained, usually at least pairs of people who go out into the community and provide on-site emergency mental health services to people in need. The credentials that people have who are providing crisis services are not the same across mobile crisis teams and models. And so the teams themselves can look very differently. And the way that they operate is very idiosyncratic across the country, and really from county to county. The goal of crisis intervention is to stabilize the situation and ensure safety, provide appropriate care and support. And in doing so, mobile crisis teams can deploy a variety of interventions, from using de-escalation techniques and offering voluntary hospitalization, if it's available in their area, of course, to things like calling law enforcement or involuntary hospitalization. But one of the things that makes me very interested in this is what mobile crisis workers actually do out in the field very much feels like a black box. It's unlike other kinds of mental health services that are occurring within an organizational setting where there are other people around, and where it might be easier to really understand interventions as they're unfolding. Whereas mobile crisis is happening out in the field, there are not necessarily administrators directly around, or managers or things like that to observe what's happening, and it's hard to know exactly really what's happening because of that. In general, I am very interested in any situation where the automatic response is to put social workers in and assume that, inherently, because they are social workers, they will do a better job than anybody else. And that includes law enforcement. And we have a long history in our profession of coercion and harming in the name of helping that sometimes is not fully interrogated. I think when we do suggest just replacing law enforcement with social workers. So that's part of what really drives me to this. And when I talk about coercive strategies, what I mean are those things like involuntary hospitalization and calling law enforcement, which happens frequently in mobile crisis team interventions. And of course, these can have negative impacts on service users. It can, discourage future service use. It can negatively impact providers. Involuntary hospitalization is, there's a lot of secondary trauma that can happen there. And then, of course, there are all sorts of impacts that it has at a system level, including economic. It also, overuse of coercion conflicts with social work ethics, in terms of respecting the dignity and rights of the person, and should be used as a last resort. And there's also potential for bias and perverse outcomes in the deployment of mobile crisis services. For example, service user race and racism can significantly impact decision-making among mental health professionals in general. We know this from the diagnostic literature. The role of disparate treatment versus disparate need in shaping those disparities, and disparities in coercive interventions, is really poorly understood. So how much is really related to bias and specifically racism versus disparate need, things that are happening upstream that are causing people of color perhaps to use services more often, or less often, I should say. And service users with prior involvement in criminal legal systems may be subject to more coercive interventions just by virtue of having a criminal record, and not necessarily because, the prior offending is linked to any current risk of or dangerousness. Further, known legal system involvement or having a criminal record could interact with service user race to differently affect. Here we're talking mostly about African American and Black-white disparities, and so sorry, those two things could interact to differently affect Black service users and white service users. So to kind of sum that all up, the motivations for the study are to really understand that black box of mobile crisis and specifically the factors that influence crisis workers' decision-making in the field. It's also to fill a gap in the literature on the impact of service use characteristics on coercive interventions in mental health services in general, and to address disparities in mental health services based on race, specifically anti-Black racism and criminal record. And, the larger goal to inform policy and practice in mobile crisis response services such that coercion is minimized and service users equitably receive services based on actual need and not race or criminal record. So what did we actually do to understand this slippery phenomena? Our research questions at the start of the study are that what is the impact of service user race and known prior criminal legal system involvement on mobile crisis workers' use of coercive interventions, and do race and known prior criminal legal system involvement interact to impact the use of coercive interventions? And we hypothesize that workers will endorse coercive interventions, specifically involuntary hospitalization and calling on law enforcement, more for Black service users and those with unknown prior criminal legal system involvement. And we also hypothesize that prior criminal legal system involvement will moderate the effect of race, having a larger effect on coercion for white service users than Black service users. And that's based on prior literature in other areas where we find that in general, mental illness when occurring in white people and African American people can have a leveling effect in disparities. So an equalizing of disparities across African American and white individuals. And the design that we used to answer these questions was an experimental vignette survey design. It's a 2x2 factorial. So we have race and known prior criminal legal involvement varying across 4 scenarios, which Priya will explain in a minute. And all of the participants they're mobile crisis workers from across the country. And they were all blinded to the independent variables of interest. So they were told that they were taking a study that was to understand decision-making among mobile crisis workers and factors that impact mobile crisis worker decision-making, but they weren't told that we were specifically interested in race or known prior criminal legal system involvement, and they weren't told what outcomes we were interested in, that we were particularly interested in these more coercive outcomes. So in terms of where we are in the study, we first conducted an expert review and consulted with 9 clinical and methodological experts to develop the vignettes that we used and our measures. We then piloted the study with 34 of our direct practice mental health social work students. And then we conducted the full study this past summer, recruiting mobile crisis workers from across the country. And this is our first foray into disseminating any of this work. So I will hand it over to Priya, who was really integral to the design and piloting and full implementation of the survey itself.
Thank you, Dr. Jacobs. So I will talk a little bit about how that experimental vignette survey design actually looked in the implementation. So we utilized REDCap survey software to create the survey, including the vignettes within that. The vignettes were modeled off of existing crisis caller intake forms at an actual crisis service to increase the likelihood that the format of the vignettes were something that the participants, the providers were familiar with engaging with. So as we discussed, the survey design included 4 different vignettes that were randomized to our survey participants. And this took place in kind of 2 parts. So we had a scenario 1 and a scenario 2. So the participant was first provided with a low to moderate risk scenario, followed by a series of questions that assessed our dependent variables, including law enforcement and involuntary hospitalization. And then this vignette was provided again, but with an increased level of risk. So it was the same caller was calling back, and it was a heightened risk. We categorize that as moderate to high. And they were then asked a repeated series of the same questions, assessing those same variables, word for word the same. And so you can see in the text on this slide that the low to moderate risk and moderate to high risk vignettes, in order to kind of bring in the prior criminal legal system involvement, we mentioned the caller's relationship with their probation officer. And in the vignettes where we removed the presence of criminal legal system involvement, this mention changed to a neighbor. So kind of seeing if the providers were picking up on the mention of them being involved with the legal system previously. And then within the caller information, you can see the race would change between the vignettes depending on how it was randomized. I think we can go to the next one.
And I'll just add one thing to that. So we're actually using like a repeated measure design here because we are presenting the 2 scenarios per person.
Thank you. Yes. So for our survey measures, as I mentioned before, our dependent variables of interest were the providers calling for law enforcement or pursuing involuntary hospitalization based on the scenario that they were presented with. And we measured this on composite scales. So this included asking the provider the likelihood of the mobile crisis team pursuing an intervention based on the vignette, the appropriateness of pursuing the intervention, and whether or not the provider felt that a supervisor would recommend pursuing that intervention. So the providers were given a variety of different options of intervention. So these included a range from de-escalation strategies, community-based supportive outpatient services, voluntary crisis stabilization, including psychiatric inpatient services. And then we also had referring to voluntary crisis stabilization or hospitalization, but pursuing involuntary hospitalization if the caller declined, pursuing involuntary hospitalization, calling for specially trained law enforcement, calling for law enforcement, and then calling a support person or peer. So we really had a range of interventions to mask kind of what we were looking at, but then also giving us kind of more of an insight into what Dr. Jacobs referred to as the black box of mobile crisis services. And so an example of how this questioning would have looked for the intervention of involuntary hospitalization. Given this limited information, please rate the likelihood the mobile crisis team would pursue involuntary hospitalization. Given this limited information, rate the appropriateness for the mobile crisis team to pursue involuntary hospitalization. And if the mobile crisis team sought consultation from a supervisor, rate the likelihood that the supervisor would recommend the team pursuing involuntary hospitalization. And with this questioning, the third person framework was very intentional in the sense that removing the provider from the questioning kind of reduced the likelihood that they would see that as, implementing their social desirability responding in more of this hypothetical framework. And then our other measures, as I discussed on the last slide, we had these 2 different risk levels. So scenario 1, low to moderate risk, and then the second scenario of moderate to high risk. We also looked at perceived dangerousness of the caller. We collected demographic and professional characteristics of the providers that we were able to recruit during our process, which will be important to look at later. And we also looked at descriptors of local service context so that we could kind of understand what are the bounds of the services that these providers are working in and how is that impacting their responses. Perceptions of services, involuntary hospitalization, and law enforcement. And then through our pilot survey, we were able to gather support for reliability and validity. So we saw high correlation between coercive interventions and low correlations with non-coercive interventions, which pointed to construct validity. And an example of this was in our pilot survey, we saw between providers choosing law enforcement deployment and involuntary hospitalization as being appropriate, we saw a correlation of 0.62. But for a correlation between law enforcement deployment and the appropriateness of de-escalation, we saw negative 0.27. So that was just kind of demonstrating that sort of construct validity that we were looking for. And then our Chromebox Alpha for law enforcement and for involuntary hospitalization, which showcased internal consistency from the pilot survey, was 0.88 for law enforcement and 0.92 for involuntary hospitalization. So that kind of all rolled into our support for moving forward with the full study. I think that was the end of that part.
Thanks, Priya. And I'll just add that Priya's presentation of results from the pilot study actually won the Health Disparities Poster Competition in the School of Public Health this past year. So further demonstrating how awesome she is. So for our sampling, this is just an availability sample, as is common in experiments. We actually drew from mobile crisis workers, and we recruited them primarily through professional organizations and networks. This is kind of like the best you can do when you're trying to recruit these kind of subpopulations of professional groups that don't necessarily have like a national organizing body of any kind that you can use as like a sampling frame. And it was very successful. Like I thought we were going to have a really hard time getting people to take the survey. But it did have the drawback of disproportionately like tapping into some of the specific types of mobile crisis workers. And so we'll see that in a minute. And in terms of statistical analyses, using a mixed linear model with a main effect for independent variables of race and known prior criminal legal system involvement, and an interaction effect between the vignettes themselves and the scenario that they were in for risk. And then we have a random intercept for participant because we have multiple observations per person. And I will hand it over to Catherine to talk a bit about our sample.
Okay, so I am actually going to fly through the next couple of slides. We're happy to go back and talk more specifics about the sample description. But the key takeaway from this section is essentially that across our 4 sample conditions, looking at race and prior criminal legal involvement, we had very good balance across the 4 groups. The average age for respondents was about 40, plus or minus about 11 for the standard deviation. Our sample was almost 3/4 women and over 70% white. And again, these were distributed quite evenly throughout the 4 different conditions.
Oops, sorry, totally hit the wrong slide.
A little bit more, we asked the respondents about whether or not they had a peer identity, which is a very specific identity in mental health for whether someone has some type of diagnosis and is serving professionally in that role. And about a third of the sample did identify as peers. Conversely, or a little bit interestingly, we saw about 20% of the sample total say that they had a severe mental illness diagnosis. And about half the samples said they had a family or friend with SMI. So we were really thinking about, if people are responding within this situation, who else might they be picturing in their brains as they're doing this? Within the professional, was sort of a little more the professional background. Our sample was about 2/3 mobile crisis team members, or as we're hoping, people who are actually answering calls. And then the sample was quite highly educated, with almost half of the sample having a master's degree. Most of the respondents had a social work background, but we also saw representation from counseling and psychology, and other was kind of all over the place. And then the sample, at least for whether or not that how long they'd been in their current position, was about 1 to 2 years. Most frequently 1 to 2 years. This was a pretty highly a decently knowledgeable sample. Total time in mobile crisis, the most frequently selected response was 1 to 2 years. Time in mental health total, the most frequent response was over 10 plus years. And then, as Leah did mention at the beginning, we did see an overrepresentation of the crisis intervention team model. So that definitely potentially came across in our results. And then finally, I'm presenting the actual mean responses for the interventions by vignette. So what you can see here are the scales for each of the 8 interventions. It's a little bit blurry on the screen, but from left to right, it's the de-escalation scale, the support person scale, the community-based services scale, crisis services, voluntary hospitalization, involuntary hospitalization, which is in the first red box, specialized law enforcement, and then law enforcement is the one all the way on the right. And as you can see, again, all the way throughout our sample, things are pretty evenly balanced across the 4 different conditions.
So just looking descriptively, we are not seeing much variation here across our treatment groups, and only a small amount of variation across the different types of interventions, though the really low coercion interventions of calling a support person and connecting the service user to community-based services were endorsed less frequently. So I feel like we need a drum roll, though I guess this sort of ruins the climax. But first, we're presenting our results, our inferential stats results, focused on the outcome of involuntary hospitalization. Before I even start to interpret any of this, I do want to emphasize that these are really preliminary. This was the model that we proposed using, but I don't think it's actually probably the best fitting model. And so, of course, we need to formally test model fit before moving forward with any, firm claims about anything. And I also know how much fun it is to interpret categorical by categorical interactions. I know that's everybody's thing they want to do on a Friday afternoon. So I will spare you, but I want to highlight a couple of things. Basically, what we see is that there is not a statistically significant main effect for any of our groups. The only statistically significant effect is for the scenario. So as crisis workers moved from reading the vignette that was low moderate risk to the one that was moderate to high risk, it increased their endorsement of involuntary hospitalization by a little over 2 points on a 15-point scale. And I think it's a lot easier actually to understand these coefficients graphically. So here we're seeing the low moderate risk scale response, or sorry, the low moderate risk scenario responses are in blue, being, endorsing involuntary hospitalization less often. And then the moderate to high risk scenario is the orange, being endorsed more frequently than the lower risk, which we would, expect. But what we don't see is any difference across our vignette with a Black service user and no prior criminal legal involvement, our vignette with the Black service user and prior criminal legal involvement, our vignette with the white service user and no prior criminal legal involvement, and our vignette with the white service user and prior criminal legal involvement. And further, when thinking about the interaction between the scenario risk level and these the vignettes, the differences between the blue and the orange predicted outcomes are almost the same across vignette. And our results for calling law enforcement are similar. The primary notable difference here is that the scenario remains the statistically significant main effect, but it is the effect is larger. So here we see a 3.5 point difference moving from the scenario A and scenario B, or from lower risk to higher risk. And the graph looks, remarkably similar to the involuntary hospitalization results. So that sets us up for discussing these results together. But first, of course, I wanted to mention some limitations. So in any kind of survey design, you have concern about social desirability responding. So, this idea that people know that, racism exists and they are racist and therefore will adjust their responding to mitigate that, so that they don't look racist. And, therefore the responses are not going to reflect real world realities. There's also the potential for our skewed outcome data to affect our results. So like, if you remember that bar chart, like all of the responses, especially our coercive responses, were pretty close to the ceiling. So there's just not a lot of variation to even necessarily like see an effect. And we can talk about reasons for that a bit later. Our sample, we have some indicators that this is not completely representative probably of mobile crisis workers, though like what we know about the mobile crisis workforce is not, like, we don't know that much. So it's hard to know exactly how this is not representative, but we do have a large representation of managerial staff. So, those managers who are like more inclined to be sitting at a computer during the day and got the email to participate in the survey responded. And then we have that overrepresentation of CIT related mobile crisis workers. So those mobile crisis workers, by virtue of being connected to crisis intervention teams, they work inherently with law enforcement. So that's going to shape their responses likely. And then the scenarios themselves, so the vignette is only taking one slice of the mobile crisis intervention. It's really just looking at, the effect of race and known prior criminal legal involvement at the point of dispatch. So it's like, to put you in the moment, it's like when they get a call and they look over the dispatch information and they're on their way to the actual site of the emergency, and they're like thinking through like, oh, given what I know from the dispatch, what kinds of things might I be doing once I get there? And that's like a perfectly legitimate slice to look at, but it is not the entire mobile crisis response. So I am really interested in hearing from you how you make sense of these findings, primarily null findings. And we've done a bit of interpretive work on our own, but I want to kind of save our ideas to hear from you what you think. And also happy to answer any questions if things were unclear.
I can go ahead and moderate. Sage, did you have a question?
Oh, no. Were you just asking for thoughts? I just had a thought. That's all.
Yeah, I think that's what conversation is usually informal. It's just that it's so hard to manage on Zoom if you know, to have an actual conversation. So I'm happy to moderate. So Paige, do you want to go ahead?
Yeah. So I think the first thing that kind of came to mind is I'm just wondering if part of the like not finding difference between like race and the history of previous law enforcement is that some of the bias might be in like the actual report. Like you guys kept it the same, just changing like the race and the like severity of the call, but I'm wondering if like the actual like documentation on the front end might be different depending on like characteristics of the page. You know what I'm saying? So like if I'm getting a call and I know that the person has like a history of legal involvement, I might be writing it as like more severe than if I don't know about the, you know what I'm saying?
Yeah, I totally get that. So it's, I think, less of a concern with internal validity, but more of a like keeping in mind the way in which the vignette provided shapes the responding, and that other characteristics that are like embedded in the vignette could alter thinking. Yeah, that's a great point.
Betsy?
Hello. I'm just wondering how you deal with kind of prosocial bias in work like this, of people know what the right answer is and that they shouldn't be taking race into account. And so when they have a chance to think about it and read it, they answer correctly. But that's not how they would react in the real world. Is there a way to triangulate or do anything? I'm just curious how people deal with that.
Yeah, I mean, two of the ways that we tried to address that risk were by blinding the participants to what we were interested in studying. So not saying like, you know, this experiment is to test the impact of race or known prior criminal legal involvement on coercive interventions. And so we did that both in the independent variables and the dependent variables. And then in addition to that, oh, gosh, there was something else. I was just on the tip of my tongue. Oh, it'll come to me. Sorry.
I'm sure it'll come back to you. Sarah, I think you had your hand up next.
Yeah, my comment comes really nicely after Betsy's, because actually what I was thinking about even before she asked about triangulating, like to me, this seems like a wonderful opportunity to do in-depth interviews with some of the participants, because I think especially around the social desirability bias, like getting people and like talking through these scenarios and hearing them think through it, you may find some more nuance there, and even might be able to engage with what Paige was talking about, which I think was also a really important point.
Emil, I see you have your hand up.
Yeah, and I'm like looking for the article right now that I cannot find. And I feel like I'm kind of, I don't know, I just like applaud you for trying to use survey methodology to figure this out despite the limitations, because it's just really hard. And I just want to say I don't like survey methodology is not my thing. So of course I'm going to see limitations. But when I was doing stuff around teaching suicide assessment, one of the things that I read that I'm going to try to find the article was they did like suicide assessment role playing with trained actors. And what they found is one of the things that dictated how somebody responded to the person was their own personal level of like PTSD symptoms, like the clinicians. And so I'm wondering like how, I mean, I don't think that's something we can address in survey methodology. But yeah, I want to find that and send it to you because I think there is a really, and also my experience being a clinician, there's a really big difference between what you think and then when you're in somebody's home or like going into somebody's home. So it's not that dispatch moment, which I know is not what you were studying. But I'm curious how like, PTSD can interact with racism and like preconceived notions about the criminal legal system when it comes to crisis workers and violence. So yeah, that's just my thought, but I don't know how productive it is.
No, well, I mean, so I actually want to speak now to like the past 3 comments. So, Emil, you are bringing up a great point, and it actually aligns well with the literature on like law enforcement use of force and factors that influence use of force and like racially biased use of force, which include the level of anxiety that the law enforcement officer is experiencing. Like, people don't make very good decisions when they're anxious, and perhaps, any attempt people are making to not be racially biased is overshadowed when they're experiencing some sort of like anxiety or a trauma response. So I would not be surprised. And related to that, and to your great point about interviews, Sarah, of course, like open-ended responses on a survey are not interviews, but Priya and I have also been coding the open-ended responses to questions on the survey. We asked like what the greatest challenge was in about being a mobile crisis worker. And that has been really illuminating. And one of the, I would say like the top 2 kind of categories that we find are resources, like without a doubt, like they are just like working, there are not other options, like, in terms of using or overusing involuntary hospitalization, like if that's the only tool in your belt, like that's what you have to use. And then another thing, like I think the second one probably is like impact on mental health, a bit to your point, Emil. And then back to Betsy's point, I remembered what I was going to say. And Priya touched on this a bit, but one way of mitigating social desirability response in vignette survey designs is by not putting the person in the situation itself, but asking them to consider what other mobile crisis workers will do in the situation, which is supposed to mitigate social desirability responding.
And I see Dr. Jones, Dr. Toya Jones has a question or comment.
Yeah, I think Leah was going down the road that I was going down, but what I was thinking is bias tends to come out involuntarily. And when you are in a crisis frame of mind, when you're answering crisis calls and you're in a crisis frame of mind, that's when the biased decisions will come out. When you have opportunities think about, and this is something Dean Farmer said too, have an opportunity to think about what someone would do or what you would do, no matter how the questions frame, we always go internally first and say, what would I do in that situation? But it comes out as, what am I supposed to do in this situation? When you're working a crisis hotline, it's what you are doing in the moment. So that was, first of all, I applaud you for this, and I was glad to be included in on something so important, because when I was working hotline like 50,000 years ago, you really just, you do what you were trained, but you also reach into that bias that you have, and it's not something that you are consciously thinking about in that prefrontal lobe. You are doing that automatic response, which is usually bias.
Thanks, Toya.
Travis?
Yeah, I think so. I had like two thoughts that I was thinking about. The one I really resonated with when you made the comment that the coercive actions were pretty high, pretty close to the ceiling. I think to me so that in itself is really interesting. And I think that when I think about that, there wasn't much differences found. It sounds like that could really account for it, because I think like when we think about bias in the way that obviously factorial surveys are not perfect at really replicating what happens in the real world, but the idea behind them is that like they activate people's implicit biases, because I would imagine that a lot of the participants, so if they read the information about race or the content on probation, I mean, that content is so brief and presented in a subtle way. The factorial surveys are created in a way where it's supposed to kind of activate people's implicit biases without them being consciously aware. So it is kind of like they're designed to have less of an impact in like activating people's social desirability bias. So I think it is interesting, but like when you talked about how close to the ceiling it was like, how would you find, I mean, like if people were already reporting that high of level of coercive action for people who aren't involved in the criminal justice system, how would it is like it's really difficult to be more coercive to people who are involved in the criminal justice system. And I had a friend, this is the last thing. I saw a factorial survey years ago from a different PhD student at Penn. And so he used a factorial survey looking at factors that impact shared decision-making with people with mental health conditions. And sure enough, he did find that when the client was reported as having a substance use disorder, the therapist was less likely to engage in shared decision-making. And I think we would have expected the same, like, I feel like we could be making the same argument about he shouldn't have found that result because the participants should have also been affected by social desirability bias. But factorial surveys really are created to try and avoid a lot of social desirability bias. So I don't know. Interesting. But the coercion was so high. That's where I'm like, it's amazing.
Yeah, it is really astounding. Travis, would you send me that paper, or like if even the person's name, I can dig it
Yeah.
up.
It was by Jonathan Lukens and Phyllis Solomon.
And there was something I was gonna say too. I mean, we don't know like why we're seeing that ceiling effect. Like, is it determined by these service constraints, or is it because the person in this scenario, featured symptoms of psychosis, and that primes people to just like immediately presume more dangerousness? But I do think there is a real risk there. And I'm wondering, Travis, if maybe the findings in that study were in part because that wasn't this sort of like emergency crisis situation. So the issues that were being brought up before around like, we're just not seeing it because this isn't the like sort of high stress moment. Yeah, like that might explain the difference between the two studies also. And since we're starting to get into some of the things that we've been talking about, I'm just going to put those up. But I know Cecily also, I think, had.
Yes, and we're coming up on time. And people who can stay, that's lovely. But I know people will be coming up on their time. So Cecily, you've been waiting very patiently.
Thank you. Thank you for this work. Thank you for your interest in doing this work. And as I listen to you, I have read Walter Gilliam's work out of Yale for teacher bias, and where I thought was interesting and kind of connected that there was more teacher bias around understanding or knowing more contextual factors of the person's story. And so I just could imagine, as a practitioner myself, as I entered into people's homes or I talked to them and learned more about their stories, that increased maybe the opportunity for this to be a, the fact that my decision making would be influenced by these additional factors. And I think that might happen also around bias, is that understanding or knowing something that that you think might speak to the greater society's messaging around certain groups will start to make you also think along the lines of that. And so I think the bias just creeps in because you start to believe whatever the message is, right? So I think maybe if you were talking about a client having poor living conditions or something along those lines, again, I just think those are some of the things. So as the scenarios are being read, if there was more context other than their maybe diagnosis or their criminal history, then it might lend itself for more folks to have to think it through and really wrestle with what their beliefs are around it. But that's just a thought.
Yeah, Cecily, I love that you brought that up. And like it's kind of like the perfect, I don't know if anybody else has their hand up, perfect last comment, because it's really at the heart of where like my thinking is anyways on interpreting these results, that like we, the vignette surveys are good at getting that like implicit, bias. And we think a lot about racism now, I think, through the lens of the implicit association test. And while like certainly implicit bias exists and is important, like racism also comes out interactionally, and like that's what is not captured here, right? It's not the process of like going into someone's home and actually interacting with them, actually seeing their environment. And those are all other vectors for racism to emerge. Priya, do you want to make the last comment?
Yeah, I just wanted to add, I think looking at point number 3 on this slide here in our interpretations, again, very preliminary, but kind of looking at the real world constraints, something that Dr. Jacobs and I have been seeing in our analysis of those open-ended questions is a lot of responding of providers saying that they feel there's a lack of, they are responding to subacute mental health experiences, but there's a lack of resources that fit those experiences to refer patients to. So a lot of times what we're assuming ends up happening is they are involuntary hospitalized because that's the option that they have in their toolbox, which I think Dr. Jacobs had here. So kind of putting that together with seeing this like kind of reaching the ceiling on these for all scenarios for these 2 coercive interventions, there's something to be said for kind of, is that the constraints that they're working in? And at what point is that a race issue versus is this just what they have to work with to provide to all of their patients if there's a lack of other subacute options? So I think that's just something that we're also exploring as well, if that makes sense.
Thank you so much for this really wonderful presentation. Very important work and a wonderful discussion. I don't see that anybody else has their hands up, and it's 1 minute to 1. So if anybody would like to stay and or can stay, I don't know if the research team is able to stay, but I'll just keep the link open until people are ready to leave. So thank you very, very much.
Thank you, Katie, for facilitating. And thanks everyone for sharing all your ideas. So Katie, if you do use like if